Okay, so the problem is that we use the word concussion and people say this is a diagnosed concussion, but there's a problem is that, the term diagnosis needs that thought bubble of what's going on underneath. Diabetes was, we didn't know what it was. Back in the Greeks' day, they just water passing through. And consumption was this mysterious illness that nobody could treat it until the late 1800s when they discovered a bacterium. So let's kind of try to think about aiming towards that type of world where we understand the underlying pathophysiology of concussion so that we might treat it. The interesting thing is, why did this become popular? I think it became popular for two reasons. One is that there's more and more awareness that about 20%, at our center, of 20+% of individuals with concussion have persisting cognitive dysfunction. They're not going back to work, they're not going back to school, they're frustrated with the medical system. And the other reason is the worry about things like CTE and all the shark in the water headlines. It is very dire. So let's try to take a look at these things and try to dissect, which may or may not be important. That's not funny? Oh, sorry. Okay, so the idea is that, like everything, this is not, like many things, this is not a gram-positive kind of diagnosis, bacteria diagnosis. This is going to be complex, but we still need the diagnosis and understand the range within that diagnosis. Before I go on, has anybody noticed the ironic similarity? Yeah. This is okay, so this seems like a bit of a joke, but it's true that males are crazy. That the Y chromosome kind of cuts off the blood supply to the frontal lobes, and so when we do studies, it's dominated by males. And we also, IRB and NIH often gives us a hard time about our distribution. It's just, but the women aren't that dumb to do this stuff. But maybe that's changing we have Title IX in the US, more women are participating in sports. But we do actually have some evidence that women, given the same sport, like soccer, have a higher rate of concussion and a worse outcome. So this is kind of concerning, and maybe there's a sex difference in concussion. And, I'm going to focus on diffuse axonal injury, but I'm actually going to show you other neuropathological changes. So concussion, you have an MRI or CT, and it's read as negative. I had an MRI, and I was told there was nothing there. So, they're normally read as negative, but we know by the symptoms something is going on. And we believe that it's really due to the damage to the axon tracts within the white matter. It takes 100 axons side by side to be as wide as a human hair. They're highly organized, anisotropic. And that labile structure may render them particularly vulnerable to damage. And I'll show you how that happens. So we have the injury from various means. As I mentioned a lot of times, it's the Penn teaching tool that we have. And either something hits the head hits something, you can have rotation without any impact, and that causes the brain to rapidly deform within the skull. The tissue moves around very quickly. And maybe one way to stabilize that is to have evolution to put in a falx, which is a rigid membrane coming from the dura that separates the hemispheres, kind of like a rudder, so that as you move your head around, the hemispheres aren't moving back and forth. But under concussion or more severe traumatic brain injuries, that falx holds back the following hemisphere while the leading hemisphere pulls away, and it's kind of like a wishbone effect. So if a neuropathologist has a brain of someone who died recently from an accident or whatever, they suspect diffuse axonal injury, the first place they're going to look is in the splenium of the corpus callosum, kind of the crossing fibers between the hemispheres. And the real issue is tensile elongation. So you can stretch things. Many parts of the body will tolerate stretch. I'm bending my elbow, the nerves in my arm, that's excursion, that stretch is about 70% strain. And they tolerate that. I hope they tolerate it. And it just goes back and forth. But under dynamic loading conditions, that's where you kind of run into trouble because of classic viscoelastic effect. We think that axons or structures within axons act stiffer the faster they're manipulated, the faster they're deformed. And you end up with the classic kind of what you see under the microscope of axonal pathology and trauma, traumatic axonal pathology, where we have these kind of ballooning of structures. I'd like you to remember amyloid precursor protein. It's this gold standard stain. It's a protein that accumulates in these swellings. Basically, transport's interrupted, and you end up with all this mess piling up inside these structures. And studying this is a little tough because rodents are expedient. You can get a large number of rodents, and on many, many models we use them. Many people do. They have like impact models. People call this concussion. I review grants and I see a contusion that's almost half the hemisphere wide in the so-called concussion model, where humans it should be CT negative. So rodents are not only just these party animals that we have to worry about, but their brains are extremely small. 2-gram brain, lissencephalic, very small amount of white matter, very different than a human. And what was discovered years ago by Holborn is that it's really about the mass. Now this is a kind of a complicated scheme, but this is really head rotational acceleration, and that is all relevant to the mass of the brain. How much the brain weighs to create mass effects that shift it around so dramatically. The human brain may be uniquely vulnerable to concussion. And as an example, if you were in a car crash with your dog, and you're out cold for 5-10 minutes, and you wake up, the dog's licking your face, wagging his tail, because his little 70-gram brain did not have the mass to pull and deform itself like your 1,400-gram brain does, or my 1,700-gram brain. CSF, I'm sorry, Charles. You can take care of that for me, maybe. Okay, so what are the structural issues within axons that are the problem, that really can't tolerate that dynamic stretch? And we've developed an in vitro model where we can culture cells on a cytoplastic membrane, a stretchable membrane, and pattern them, micro-pattern them, so they really look like white matter tracks. So gray matter to gray matter, spanned by the white matter tracks. In this case, we can light it up by tau protein. Tau belongs in axons. It's an axon-enriched protein. It's a microtubule stabilizer, basically. It's selective for axons. So, why did nature put tau in axons? That's crazy. Anyway, please remember that one as well. So we can we put the axons perpendicular to that gap. We stretch the gap that causes a tensile elongation. We use parameters based on human concussion. And if we stretch them slowly at just 100% strain, twice their length, they come back and they're unharmed. But if we induce this dynamic loading, we see undulations. Much the same as you would with a bungee cord. You stretch it, everything's fine, but something breaks inside and that thing's all undulated. Everybody's seen these bungee cords. Something is impeding relaxation to that normal straight orientation. And we think that is responsible for eventual types of accumulations of protein. So that interrupts transport within the axon. And case in point, here is these swellings that we see in a sea of axonal pathology. But if you notice, we have the undulations here. So the undulations evolve towards these swellings. So the breaking of something, and we believe it's the train tracks of the axon. The train tracks that transport proteins, microtubules, are responsible. And here's, closer up, this is these are in humans, these undulations, which are, widely seen, not widely described in neuropathology, and in a pig model I'll describe as well. And if we use electron microscopy and drill down into the axon, look what's happening at these undulations. At the peak of the undulation, we see these dark lines are microtubules. Those are the train tracks. And at the peak, the microtubule has ruptured, has disconnected. It physically broke. Your brain can physically, mechanically break at the very moment of injury, down at the nanoscale. And that physical breaking doesn't just happen by just simply pulling and it stretches and lets go. There's something else at work here. This is also kind of a complex system. I'll try to keep you away from these weird Greek letters. That these tubes are microtubules. They're spanned by that tau protein. It's stabilizing them. Tau is supposed to keep that very orientated, regular, parallel structure of the microtubules all sitting, going longitudinally within the axon, or in Canada, you say longitudinally? Is that the? And basically, the idea is the axon, as it stretches, the microtubules have to slide past each other, which means that the tau proteins have to kind of unfurl from the resting state. So they're kind of at a resting state, kind of stuck together and kind of unfurl and let go of these H bonds, we'll call them magnets. And the way it kind of works is think of like a piece of yarn with a bunch of magnets in a relaxed state. Some magnets dock and you have this kind of bundle of yarn. But as you pull it apart, you pop, 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 a little bit of energy to pop off each H bond, each magnet. Under dynamic loading, however, it's so fast that you're trying to pull all the magnets at the same time. So that causes extremely high stress, high forces at the attachment sites, the tau binding sites on the microtubule, and that can cause the microtubule to rupture. That as you're sliding the microtubules, the tau pulls and pulls until that spot will rupture, much the way that you see these kind of, where normally they would just slide and the tau would release, but at various locations along the microtubule, you end up with these ruptures, and then you lose the cargoes in green here that can cause this ongoing unmitigated swelling because you keep dumping material into that site as the cargoes are dislodged. And this is kind of weird. It's not just at the level of just one site in the axon. It's along the whole axon that we see in this in vitro model. And we also see, and this is a human case here, that you have periodic swellings, we call them varicosities, in the axon. And we think that that might be due to multiple sites of breaking along the axon. That it's really at the level of the microtubule that you break at one site, you'll dislodge some cargoes there and you end up with swelling, but some material can continue through only to be dislodged someplace else. So this explains that very characteristic varicosity type of appearance that we see under the microscope. Okay, so but the issue is that it's not just that you see this kind of swelling. And as neuropathologists would look at, they say that's how they diagnose this. But we should all recognize that that's just the tip of the iceberg. That within that field that you're looking at, there might only be a few axons of consideration. The entire tract received the same injury. Those other axons didn't go to the point of having all the breakage of the microtubules, disruption of transport, but they were injured in another way. And we really suspect that because the patients are really symptomatic. And a couple of swellings we don't think would really explain that dazed and confused loss of consciousness or at more severe levels of injury, coma. So what is going on otherwise? Well, if we, again, back to the in vitro model, if we look at dyes that can light up sodium or calcium, and we see before and after injury at a very low strain, at a high strain rate, very quick stretch, nothing happens, but that's a very low percentage strain. But even as you go up just a little bit, you start to see sodium and calcium pouring into the axon. That's not a good thing. And it continues at different levels, even to the point where you start breaking the microtubules and getting the undulations. And this is a complicated scheme, so I want to use the toilet tank to explain what's going on here. Because a toilet tank is kind of like a sodium channel. And you're up at night and you hear that drip, 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 and that stupid flapper valve. Once you take the top off, you see it's open, you shut it, and you hopefully go back to sleep. Well, sodium channel is kind of like a toilet tank, where you have an activation gate, an inactivation gate. That's really the flapper valve. Both of them open, let just the Goldilocks amount of sodium to come in. That's the spark. That causes electricity, how you get that action potential right there that can transmit that electrical signal down the axon across the electric grid to reach the other side of the brain. That's really the electricity that allows you to listen to my talk right now, except for the person over there who's sleeping. Sorry. Somebody has to sleep. But that's the normal event when then bang, the inactivation gate snaps shut, and that's it, right? Then you can repolarize and have another action potential. But in trauma, we've discovered that at first that gate is deformed, and then it's actually cleaved by calpain, which is activated by the calcium coming in, and that means that there's unmitigated flow of sodium into the axon, and you cannot form another action potential. And we really think this kind of explains the kind of loss of consciousness or that dazed or confused type of appearance in individuals. It's really across the electric grid. And I like to point out that if you were to turn to your neighbor and start to strangle them, it's going to take a little while. Don't do that. But it could take a while for that to happen because that's really hypoxic ischemia. And I even, am interested in some of these French reports of the French Revolution where decapitated heads picked up could wink or do something, Again, it takes a little while to cause the change in cognitive status. But with concussion, you can have an immediate effect, and that's because it's about electricity, that you've taken down the electric grid. All right, so what does this mean for male and female differences? So we find that in some imaging studies, there was an indication that the G ratio, the kind of diameter of axons, was potentially different between males and females. And we then said, okay, well, could there be a difference in trauma then that could explain a difference in outcome from concussion? So we grew human as well as rat axons in culture, and we discovered that indeed male axons are much wider, but even more so, really even more compelling, this is a cross-section of an axon, and these circles you see here, those are microtubules in the middle, those dark circles, that is much more complex in a male. And the females per square area has fewer microtubules, so it's a much simpler type of structure. And evolutionarily, that may be to get the same network. So females have at least the same network, and some people say a more complex connectome than males do, but they have to put it in a smaller box. The skulls are small, the brain is smaller. So one way maybe females, their axons and other structures perhaps had to be smaller than males and more streamlined. Alternatively, maybe males just lived a brutal life and needed more armor. Certainly their skulls are thicker, and we know what that means. Okay, so when we injure these axons, male and female axons, at the same kind of concussion type of parameters, we find that the female axons have far more undulations, much more microtubule breaking. The microtubules are more susceptible to damage at the time of injury than compared to the males. And not surprisingly, it corresponds to a greater influx of sodium and calcium. So picture, within a white matter tract, you have a bunch of axons. Some have just minor ionic changes. They can re-equilibrate and go back to the normal balance, maybe normal function. Others have some of that plus some microtubular or other ultrastructural changes. Maybe even they can repair that over time. But there is a tipping point. So on a given tract, if more axons shift just over that line, they may go on to degenerate, to go on to swell, accumulate axonal proteins, and ultimately disconnect. And once an axon disconnects because it's so swollen, it will never reconnect. That's it. That's permanent brain damage. So when we see this in concussion, that's, as I said before, it's like an oxymoron. That's not mild traumatic brain injury. Okay, so this is really a sex difference down to the nanoscale that we think plays an important role. It will not be the only condition, but it's at least one thing that may contribute to a differential between males and females. So let's talk about modeling moving up the food chain. So we chose a swine model where we can induce head rotation acceleration using parameters based on humans. But as I was mentioning about the size or the mass of the brain, we have to increase the forces 8-fold to create the same tissue deformations that the human would endure. So you can imagine what that would take to induce that in a smaller animal. And we do see many of the same changes, almost indistinguishable from humans, where these varicosity type swellings throughout the brain under the microscope are very clinically relevant compared to humans. But we did very recently find another change, which may have very important clinical implications, and that is a blood-brain barrier is open. There's not even microhemorrhage in this model. There are no overt, macro changes, not even microhemorrhage, but the blood-brain barrier opens up, meaning proteins like fibrinogen, thrombin, even IgG can get out into the brain parenchyma and perhaps wreak havoc in ways we don't yet understand, maybe chronic inflammation, other factors. This we just actually discovered may continue. We've looked at more severe traumatic brain injury in humans. I should point out we really need the pig model because, thank goodness, we don't get many brains from patients with concussion. So we don't get a chance to look at their brains. So the pig is kind of a surrogate. We compare that in parallel to human brains that had more severe injuries where we do have those brains. So both in the pig and the human, we see a persistent blood-brain barrier opening where these fibrinogen type of molecules you'll see out around these vessels, these dark splotches, telling us that this is a pretty dramatic effect. Well, this is important, I guess, on the positive side. This means that we have an opportunity to measure axonal proteins that could be released from the axons, or degenerating axons, go out into the blood, perhaps via that blood-brain barrier breakdown. And that would be pretty important to look at these various proteins found only in axons, because this could be akin to troponin, as is used to rule out myocardial infarction, and tells us that there's been some damage to the heart tissue. Whereas here, if you see axonal proteins in the blood, axons were damaged in the brain in concussion. And that's what we see. In the pig model, we see that with 1 or 2 injuries, we see the increase in all of the proteins I just highlighted, but in this case, it's a spectrin breakdown product. Calpain cleaved that as well, in addition to damaging the sodium channel. So this fragment, we not only know that this should belong in axons, but we know how it was cleaved. We know something about the pathophysiology. But I've also seen another protein, which I think is going to be a very strong candidate to be used clinically, that's neurofilament protein, as well as tau protein. And we've also seen this in humans. So in the ED, we recruit patients, and we found in about 20% of the patients we see SNTF, neurofilament light, tau protein. It turns out those are the same patients who go on to have the persisting neurocognitive dysfunction. So we're identifying patients at risk of issues, and that's really maybe towards a diagnosis of degenerative diffuse axonal injury, because those proteins are there because of degenerative axonal pathology. And even in hockey, we find that, or in Canada's hockey, something like that, we see that it not only these proteins are not only elevated, but may perhaps indicate return to play conditions when they might subside, coinciding when the player feels better. And we know these proteins are really what we think they are, because if we take the same antibody used in the blood assay and put it on the brain, it only lights up axonal pathology. So it's a pretty clean test. That is the source of the protein we see in the blood. Whether it's in the pig model, concussion, or more severe injury in humans. That is I think, really working towards a diagnosis of an underlying cause of concussion, not just a diagnosis for concussion. And this is really great. Just think, not far in the future, we could consider parsing out that group of individuals who are predicted to have a poor outcome. Because you can imagine, if you set up a clinical study, you don't want to enroll everybody with a concussion, because 80% are going to dilute out your effect. So you select that one group that have shown, predicted to have a poor outcome, you split them into, and you think about, maybe a drug therapy. And you really move away from these sideline tests. These are very important, not this one, but the other sideline tests are pretty important to, help screen, especially kids and whatnot. But afterwards, how do we really treat patients and think about, drug therapies? And we've actually, through workshops at the NIH, have identified many candidates that could treat ongoing axonal pathology. It's not just simply breaking. We can even use things like Taxol. Taxanes might be able to address and stabilize. Taxol binds to the tau binding site. So you can actually stabilize that microtubule with a cancer chemotherapy. Okay, so what does this have to do with neurodegeneration? Well, we find that, you remember I was telling you about that, APP being the gold standard of staining for axonal pathology? Well, APP is the parent protein to amyloid beta. So we examined human brains after traumatic brain injury. This would be more severe, of course. And we see, here's the APP staining, but within that, we see many axons filling up with amyloid beta. And this is kind of curious, because we also see amyloid beta plaques. These are diffuse plaques. But we see them in young people and within hours of injury. If a neuropathologist were to look at these sections, they say, this kind of looks like Alzheimer's disease. It doesn't have the neuritic plaques quite yet, but it looks like Alzheimer's disease, but within hours of injury. And we think that this mechanism is really caused by a unique system, not quite in the normal Alzheimer's disease literature, where APP is transported down the axon with the same enzyme, the same secretases that can cleave it to form amyloid beta. And in the milieu of trauma, it goes on and makes amyloid beta within the axonal membrane compartment. It then can accumulate into, start to turn into oligars, et cetera, maybe even protofibrils, maybe even fibrils, to the point where the axon keeps filling up, swelling up, and then it lyses, it bursts like a teenager zit out into the tissue parenchyma, releasing all these peptides, sticky peptides that can then deposit into amyloid beta plaques, or perhaps affect, we say, toxicity of various types. So I'm really kind of curious about how it affects memory after trauma, because when it binds to synapses, it affects LTP, and rodents does affect memory. So in the post-injury milieu, you have amyloid beta floating around the brain, doing all kinds of crazy things, but possibly even affecting memory. And concussion in some cases, and in many cases of severe TBI, it's an injury that can keep on taking. It's not just what happened at the time of injury and how you have that recovery. We find that axons continue to degenerate weeks, months, years after injury. Not the same kind of full extent as immediately post-injury, but they can keep going on, swelling up and degenerating at almost any time point that we examine. And that means that there's going to be a constant supply of amyloid beta that can be released out into the brain and continue that process over time. And we see that in humans, as time goes on, at more than a year post-injury, again, this is moderate to severe brain injury, we see not just diffuse plaques, but what senile fibrillar types of plaques, congophilic, that are very characteristics of a more advanced Alzheimer's disease, and to a much greater extent than age-matched controls. So we examine folks typically less than 60 years old when they died, but a certain number of years out from injury. And we recently discovered that this is all going on at the same time of a decrease in NAA. So NAA is incredible abundance in the brain, and nobody really knows what it does. It's the highest abundant amino acid, other than glutamate overall, certainly the highest in neuronal structures. And we had kind of a hypothesis, it's really an antifreeze for misfolding of proteins. And it's really easily seen with proton spectroscopy. Even we're now starting to make brain maps of NAA. And we had the hypothesis that NAA keeps the aggregation of A beta and perhaps other sticky proteins at bay by going inside the forming oligomers and protofibrils and breaking them apart. So we did an aggregation assay, and we find that while you normally march on towards forming fibrils, if you put the NAA in, it can actually slow that down or even reverse that type of effect over time. So you start to form fibrils and it gets reversed. And we think it does it by really going in between the leaves, the backbones of the forming beta-pleated sheets that can open it up to enzymes like neprilysin that can cleave the amyloid beta. So it's kind of a 1-2 punch. You reduce the amount of NAA, at the same time you're making more amyloid beta, and then that can then form, aggregate and form beta-pleated sheets that will further deposit all at the same time. It's almost like a conspiracy. What was evolution thinking? Okay, so sorry for my very bad Shakespeare here. Okay, so the thing about CTE, many of you may not know that the current definition is based on 10 cases. The 10 cases, what come from that is that we have only a preliminary criteria. And yet, I think many of you think that this is a done deal. We're absolutely certain what CTE is. It's really well defined, and that's not true at all. In fact, next week there's a CTE meeting at the NIH, and I think it's open to the public, so there'll be fireworks. I think Gabor is going to cause some trouble, aren't you? I hope so. Okay, but there are so few cases that it just kind of trickled along. We've known about CTE for decades, and despite what you've seen in movies and claims, it was known for decades, and it was defined for decades. It was really restricted to boxers. But as soon as we had football heroes and other athletic heroes, bang, we had more cases in theory, but this is really based on the definition of the person who's looking at them. And even with that number, there are more reports in the New York Times about CTE than actual cases out there. And I really have a strong feeling that many of the current cases are not going to be considered CTE in the future. But classically, it's really kind of these, see these dark dots here, that's a tauopathy, whether it's neuronal neurofibrillary tangles or astrocytic type of changes where tau accumulates. So here's a tangle, here's the astrocyte type of change. At the depths of sulci and around blood vessels is considered more classic. Anne McKee and others kind of show this here, depths of sulci around vessels, but in a way that we haven't quite set on. Is this the way to look at it in a kind of strange way of taking kind of whole mallet brain? And so that's something we might actually discuss next week about what's the proper way. So many of us are concerned that if you keep looking in any brain, like in our brain archives, we find pathology in every brain that we look at if you keep looking. So we have to consider how to standardize this and not just say a kid died from suicide after football and we found a couple smudges. That's why he committed suicide, which is just a kind of crazy link, but it's really kind of confusing society about this. And it's not just repetitive type injuries. In single severe, we see tau pathology. Now, we don't see it immediately after injury like the amyloid changes. It takes about a year plus, but we see, again, these congophilic neurofibrillary tangles after just one traumatic brain injury of a more severe dose. It's like we don't know the dose that it takes to get this, but at least severe, we have some indication as opposed to just a bunch of head impacts. And this is all in kind of think about other pathologies that occur at the same time. So we're talking amyloid beta tau, where CTE is just tau, but a lot of these individuals have chronic inflammation. These are really angry looking microglia in the corpus callosum compared to a normal control. And then they also occur in the parent with things like, really dramatic brain atrophy. Again, this is the splenium of the corpus callosum. And if you have just the normal aging individual, you don't really see much change. This is a normal size corpus callosum. But look at the injured individuals, and the dark staining is the microglia. So, that's a lot of tissue loss. And when we look for axons, we see swollen axonal profiles, APP, in that same tissue. So again, the injury that keeps on taking for some individuals. This is about a third of the moderate to severe cases. So we really think we should move away from CTE, which is becoming more and more really constricted, to a more global perspective and look at the patients, what do they really have? So we call it TBI-related neurodegeneration trend. CTE may be one type of that, but even then we're worried that if somebody is using a microscope and looking at like these tau stains neurons or astrocytes at the depths of sulci, but if they go to a lower magnification and there's florid AD pathology, what's the diagnosis? I mean, I would say the diagnosis is AD with maybe comorbidity or co-pathology of CTE perhaps, but we have to be really careful how we define this. And so we also have to talk about the clinical symptoms. How do these neuropathological changes correspond to a change in, let's say, dementia or age-related cognitive decline over time? And try to grapple with the dose. So what is it about a single severe traumatic brain injury that induces these pathologies, or repetitive mild? How much does it take? And what is the individual genetically and otherwise, environmentally, bringing to the table that causes these changes over time? And we know that maybe 1/3 of the severe TBI have some of these neuropathological changes. We have no idea what it means for repetitive injury. But I can tell you that since males dominate, concussion, that they should therefore dominate dementia, and that's not the case. So we have a lot to think about from an epidemiology point of view. But it's been very disturbing for many of us about what's been going on in the press, in the media, about all these kind of very Chicken Little reports. And we had 61 signatories really saying enough is enough. Let's just be calm and not try to scare people. I've had people email me, call me. Like recently, one young guy said he didn't want to get married because he was afraid he's going to be drooling in his oatmeal in a few years. I mean, we really have to kind of think about how to make this balance. It doesn't mean hitting your head over and over is a good thing, but we have to have some view on what is okay and what isn't. And so we're really lucky that we have set up a consortium across 12 institutions, including right here, and we're going to pool brain banks, so we finally will get those numbers and really make a sense comparison. So it won't be just some folks only look at brains of people they think have CTE and don't compare them to age-matched control. So that's crazy. So we're definitely going to do that. But in addition, compare them to neurodegeneration cohorts, people with Alzheimer's disease, Parkinson's, et cetera, to see if there are any similarities or differences or something that makes unique that trend, this trauma issue, is unique or not. So I have many collaborators. I'll just quickly note a couple of few. Oops, I keep pointing that. Is Willie Stewart in Scotland, who is, who has a major TBI brain bank there. John Georgianowski at Penn, neuropathology. And importantly, in our group, we really focus on biomechanics. So Dave Meany is a professor and chair of bioengineering at Penn because TBI is a biomechanical event. So with that, I will take any questions. Thank you.
Just a quick question. In terms of the sodium inactivation gate mechanism, do you see that as subthreshold to actual microtubule breakage? In other words, does it occur at a lower force than the microtubule breakage? And if so, would that indicate a different pathology?
Yeah, absolutely. It does occur at a lower rate. We look at sodium channels at different levels of injury in the pigs, at their changes, and the cleavage of this gate, and that does appear at a certain spectrum below where you see the transport interruption. And in vitro, we also see the same thing, where you can have the sodium channel changes without transport interruption issues. So you would expect that maybe some kind of, I don't know if I want to call it subconcussive blows, because I don't know what that means, since this is subconcussive, right? But nonetheless, we think that there are changes to the sodium channels, that can affect cognition. I think we've all hit our heads, and is it the pain, right, that we feel, or is it kind of dizziness, and would we call that concussion, or is that just something that kind of knocked things off temporarily?
In terms of models, you are very critical of small animal models for concussion. So does that mean we should stop all small animal model work in concussion because they don't really mimic concussion, or how should we behave in terms of models?
Yeah, I think that we have to be really reflective. So we use rodent models, but it's the interpretation. So if you think your rodent model is replicating the biomechanics of human concussion, I think that's probably unlikely. However, there are many models that you can perform that could induce deformation of the white matter of models that might replicate with confirmation that it does have that same dynamic loading to the white matter tract, like the corpus callosum strip that the rodents have. So it's a matter of interpretation. Instead of just boldly saying this replicates human concussion, people have to really demonstrate that and not just hand wave.
I agree with you that it's over-interpretation with rodent models, and I've sort of thought that they are meaningless, but I guess you're leaving the door open a little bit, that maybe we're learning a little bit with them.
Yeah, and I think we need to evolve. There are over 30 clinical trials that have been performed, mostly moderate to severe injury in rodents. And there's a reason why all these clinical trials have failed, many reasons, but one may be the lack of translation, that this contusion model in the rodent, just for example of how people overinterpret rodent models, people say, there's a neurosurgeon who talks to a researcher and says, listen, I have a severe patient, I just want to have something to treat these patients with. And the researcher says, well, I have a model of severe traumatic brain injury in the rodent. But he didn't say that the rodent is ambulating, grooming, and eating within an hour. It's just that if they raise the pendulum a little further, the animal would be dead by brainstem compression. So I think disconnects like those are a problem that, there should be more, cross-discipline interaction to be sure that if you use a rodent model, any kind of reduced model, is it clinically relevant?
Thank you.
Yeah.
I have a question. So in other neurodegenerative diseases, we have an increasing evidence of transmission. So in other neurodegenerative diseases, we have increasing evidence of transmission across the synapse of these proteinopathies. Do you have in your model any evidence of spread of disease?
Yeah, I would say that prion-like changes is a very popular topic. But even in AD, there's huge debate right now. I work with Virginia Lee at Penn, and she's had some pretty interesting findings in that regard.
Yeah.
But I think it's kind of because the TBI field is behind AD and others. I think let's see how that goes with them before we start jumping on the bandwagon on something that's newfangled. But you could say that when we see phosphorylated tau and amyloid beta, we see this in severe traumatic brain injury in everyone. So if this were just immediately transmissible, then the world would be a different landscape. So it's not a huge thing. Doesn't mean it's not part of the whole spectrum.
Thanks.
Thank you.
Can I ask a question over here?
Oh, sorry, go
Is that
ahead.
okay? Thank you.
Go ahead.
Thank you for the talk today. I thought it was very interesting. I had a question about what sort of velocity changes we're talking about in a person. So I'm from a clinical end, and I notice there's individuals with concussion that are sort of walking in, like getting hit by a ball or walking into a door that seem like they're relatively low velocity versus ones that would be much more significant from a fall and such. And so I'm just curious about if you can speak to that, about what kind of degree of velocity or that would parallel the kind of deficits that you're describing or the neuropathological changes that you're describing.
Yeah, so it's really the head rotational acceleration, and we know general range of the threshold, but it's complicated because there have been boxers who've been just hit with accelerometers and whatnot, and we know some of the thresholds, but there really could be other ones, or the dynamics of the head, the kinematics could be very odd. But the key here is that it has to happen probably within under 50 milliseconds. So it's not some kind of a slow effect. It has to be a very rapid effect to cause that viscoelastic response. You often see people will look at some boxers and see this roundhouse punch and the head moves and they say, wow, that's amazing. But the guy comes back and then gets hit again just on the temples and his head just goes like that and he goes down. I think, he just was diving or something. But it's hard to visualize what those true accelerations and kinematics were. And it could be something as simple as we think injuries that cause rotation transverse to the brainstem are more likely to induce loss of consciousness. So all the symptoms depend on kind of the angle of head rotation, but all I can say is it's complicated, but it's got to be, you don't know what you think you're looking at or what the patient might be reporting may not be that accurate.
Fair enough. Thank you.
Mm-hmm.
Thank you. We're seeing more evidence of the neuroprotective effects of lithium in SSRIs. Is there research in this area that you're aware of that you can comment upon?
Yeah, so actually people have recommended lithium here. So we do know that calcium is a big problem. So calcium, as everybody probably knows, can get into in this case, axons and act like Adolph's meat tenderizer and just start activating everything and it gets cut off. So you first have this mechanical injury and then a chemical injury by things like calpain. So, just one effect of lithium might help be to dilute out the calcium effect, but it would be on the list, I think a long list.
Thank you for the presentation. In terms of the sodium channel dysfunction, is this widespread, something like a spreading depolarization issue?
Yeah, I don't think it's something that's spreading, and it happens much faster than spreading depression or depolarization. So it's really all over the whole network at the same time. The entire brain is being deformed, the axons are being irritated, and that's going to happen throughout various. Diffuse axonal injury is a bit of a misnomer because it's really more multifocal as we find that axons near interfaces around ventricles or near vessels, gray-white interface are really the ones that are most at risk.
So is that something that's going to be causing the immediate clinical symptoms of like loss of consciousness and immediate like headaches and stuff like that as well?
That's right. Just anything, that this is really all about electricity throughout the entire electric grid, the network.
Thank you.
Yeah, you're welcome.
So I'd just like to follow up on a question that the woman to the right of me asked a few moments ago. So in the world which I live in, the world of medicine, the concussions are almost exclusively individuals who bump their head on the table as they pick up a pen. So that's the world of concussion I see. How does your discussion about tauopathy and amyloid deposits and calcium channel and sodium channel, how does that fit into this group? Because you talk a lot about moderate to severe TBI, but I'm talking about people who literally bump their head, have no alteration of mentation acutely, but 2 days later they're dizzy, and they're diagnosed as having a concussion. And so how does this world of pathology fit into that group?
Yeah, that's a great question. So I think what we really need to understand is dose, right? That what can do this. So it really, you think that
A bump on the head.
yeah, bump on the head. Really, we don't necessarily believe that a bump on the head would create the accelerations, or that, like I was just saying, this is sub-threshold, right? But you probably have to pass a certain threshold before you're really at that level.
So these are the individuals, though, they're being diagnosed by almost every clinician with concussion every day.
Yeah, and that's why we have to shift. There are over 30 clinical definitions of concussion. So I think we need a little bit of consensus on that. It can't, before it was a little bit, higher, that people say, oh, you just, your bell was wrong, but they wouldn't use the word concussion. But now people just barely bang their head and they say concussion. Sometimes they played football and feel depressed and they're diagnosed with CTE, which is really kind of unfortunate. So I think we're really at this diagnostic, hopefully tipping point where we're going to really get our act together and start to make clear definitions. And dizzy or headache or whatever doesn't necessarily mean concussion.